we have a 46-year-old self-identified Caucasian man who's an automotive mechanic presents to the outpatient gastroenterology clinic for initial consultation regarding a newly confirmed diagnosis of chronic hepatitis C. Okay, so it's important to highlight here that we're dealing with chronic hep C in a 46-year-old Caucasian man, and he reports feeling relatively well overall, noting only mild, non-specific fatigue. Okay, so this is the finding that we would see. Obviously, it's non-specific, but with chronic hep C infections, fatigue is often one of the signs and symptoms associated with it early on. Upon detailed social history screening, patient reports consuming 3 to 4 standard beers daily on weekdays and up to 6 beers on weekends. So that's important to note here, this alcohol use history, because for a patient with chronic hep C, we would be concerned about cirrhosis, and just knowing how much they are drinking can help with some of the risk factor mitigation. And so that's quite a lot of alcohol within a week. Continuing on here, he has no prior history of jaundice, ascites, hematemesis, or hepatic encephalopathy. So that tells us that maybe this cirrhosis that he has, even though he has chronic hep C, and he might be developing cirrhosis or high risk for developing cirrhosis, doesn't have any prior history of any decompensated cirrhosis. So things like ascites, hematemesis, hepatic encephalopathy, all those would make you think that this is a pretty end-stage cirrhosis, and he's getting very ill from that. But doesn't seem like he's at that point yet. Continuing on here, he takes no daily prescription medications or herbal supplements. On physical examination, his temperature is 98.2, heart rate 76, respiratory rate 14, blood pressure is 122/78. He's alert and oriented to person, place, and time. Sclera, anecteric, and there's no pulmonary erythema or spider angiomas. So again, these are findings you would see in somebody who has really bad cirrhosis, and also the fact that he's oriented to person, place, and time tells us that he's not encephalopathic currently, and he's otherwise still doing well. Continuing on, abdominal exam demonstrates a soft, non-distended abdomen, no shifting dullness or fluid wave. So that tells us that basically there's no ascites. He has a normal abdominal exam. Liver edge is smooth and palpable 1 centimeter below the right costal margin, and the spleen is not palpable. So otherwise, it doesn't seem like his liver is significantly enlarged, and there's nothing concerning with the size of it either. Neurologic exam reveals no asterixis or cognitive deficits. Again, you would see asterixis in somebody who is encephalopathic, and so here we don't see that. So it further adds to our understanding that he is otherwise well appearing despite having this diagnosis of chronic hep C. Continuing on here, baseline staging evaluation showed no structural evidence of advanced hepatic fibrosis. So that's great because now we have some imaging here that gives us some objective findings relative to how bad his liver looks in the setting of his chronic hepatitis C infection. So it's asking here which of the following is the most appropriate next step in management. So let's just read the answer choices here. Option A, counseling on complete abstinence from alcohol use. So that's always a good thing, especially with somebody who's higher risk for developing cirrhosis. Alcohol use can increase your risk for cirrhosis, but also the setting of having chronic hepatitis C can also raise your risk for cirrhosis. So the combination of the two actually further accelerates it compared to just one or the other. And so for somebody who is known to have chronic hepatitis C infection, trying to reduce or abstain from alcohol can actually help improve their outcomes as far as how long it takes for cirrhosis to develop. And so option A here is a pretty good next step for somebody who has 3 to 4 beers just daily on the weekdays and 6 beers on the weekends. We could definitely recommend abstaining from alcohol use. The initiation of prophylactic oral lactulose. So this would be a little too early on and probably not beneficial for somebody like him who is not having cirrhosis at this point in time, nor is he having any hepatic encephalopathy. So for that reason, B is not the best answer. Monitoring with biannual abdominal ultrasound. So you want to do this for somebody who has definitely has cirrhosis and you were concerned about hepatic cellular carcinoma. For this patient, there's no evidence for any advanced hepatic fibrosis, so the risk for hepatic cellular carcinoma at this point in time is pretty low. So it wouldn't be the next best step. Prescription of a low sodium behavioral diet. Again, if you're concerned about a lot of fluid overload or ascites or edema, this would make sense. But also from a standpoint of maybe if there's some level of heart failure, that would make sense. But at this point in time, the next best step wouldn't be reasonable to limit sodium intake. Recommendation for reduced carbohydrate caloric intake. Option E. I don't like this simply because we know that the etiology of a cirrhosis here would likely be due to alcohol use or chronic hep C. You would choose option E if you're concerned that the driver for his cirrhosis is more metabolic related. So having risk factors like hypertension, hyperlipidemia, diabetes, high BMI, those things would be sort of controlled by having this recommendation put in place. So for that reason, E is not the right answer either. So for those reasons alone, A would be the most appropriate next step in management.